Good morning, and welcome to the Cannabis and Drug Treatment Courts Project Knowledge Exchange Forum. My name is Trevor Temchuk. I'm a member of the Cannabis and Drug Treatment Court project team and bring to the project my lived experience of mental health in the justice systems. I also contribute to the Provincial Human Services and Justice Coordinating Committee as the chair of the Communications and Knowledge Exchange Committee, and also as the co-chair of the Conference Planning and Persons with Lived Experience Committees. Today, I have the pleasure of welcoming you to the forum and making a few remarks before we hear from the speakers. First off, some housekeeping items. This forum is taking place on the Zoom webinar platform, which is different from a Zoom meeting. This means that only the speakers will appear on the screen. Audio and video options are turned off for forum attendees. You will have the opportunity to post your comments on chat and also use the Q&A box to post questions for the speakers and forum host. I encourage you to use these options. We look forward to hearing from you. The event is being recorded, and the recording of the forum will be posted to the Provincial HSJCC website. I hope you're not facing any technical issues now that you have successfully signed on to the forum, but if you do, please send a direct message to Tasha Rennie on the chat or reply to the email you received with the link to join the forum. I would like to begin the session by acknowledging the land I am joining you from, which is London, the London area of Ontario. The chat is open if you would like to post a land acknowledgement of your own. We acknowledge our presence on the traditional lands of the Anishinaabe, Haudenosaunee, Loipenec, and Adirondack, and the treaties that govern them. For many thousands of years, Indigenous peoples have lived on this land, and when the newcomers arrived, they helped the first travelers to this territory and shared their knowledge for survival in what was at times a harsh climate. We acknowledge with respect to the history, spirituality, and culture of the Indigenous peoples with whom these treaties were signed in good faith. This territory includes the Chippewas of the Thames First Nation, the Oneida Nation of the Thames, and the Munsee Delaware Nation, and is also home to many Métis and Inuit people, and all of us, both Indigenous and newcomers, are treaty people equally responsible to uphold the treaties first made here. One of the most overrepresented populations in the justice system are Indigenous peoples. To me, this is part of the reason that a land acknowledgement is so important at this forum. When we talk about trauma, when we talk about adverse childhood experiences, when we talk about many of the reasons that bring our clients to our services, we are talking about the effects of not only historic events involving Indigenous peoples, but about things that continue to happen today. The word reconciliation is used a great deal, although even as a somewhat arm's length observer, I don't know that much has been accomplished in pursuit of it. At this forum, we have folks who deal with issues at the systems level and at the service delivery level. And true reconciliation would involve changes at both levels, and in some cases go even beyond that. However, I know from over 2 decades of involvement in this field that we can affect change, especially at the service delivery level. And I hope that we can keep doing that with reconciliation in mind as more than a trendy buzzword. Thank you. As I mentioned previously, we are interested in hearing from you today and following the forum. I also invite you to respond to a short poll with 3 questions that we are posting. Now, you should see a pop-up box with the questions. Let's take a quick look at the agenda for this morning. A detailed program was sent to you last week, which includes more information about the speakers. We will start with a short presentation on the background project and impetus for the research project. This will be followed by a presentation of the community-based research and the results. The keynote by Dr. Akwaze Osobempa will be shortly after 10 a.m., followed by a 5-minute health break. We will hear from a drug treatment program service providers after the break, which will be followed by a moderated discussion. Please note that questions that you have for the speakers, including the keynote, will be brought forward by the moderator for a response during the Q&A session. Send us your questions at any time during the presentations. And I don't know if we have the results for the poll yet.
I see some folks are still completing it, so I'll just give it a few seconds here. Okay, I'm going to pull it up.
Okay. So a lot of people from Toronto, but also great to see a lot of people from Northern Ontario. And quite a few people who are community-based providers, as well as a lot of people from the justice and legal system, which is great to see. And lots of people here to learn about drug treatment courts, which is great to see. So thank you for that, everyone. I hope that this forum is of interest to everyone, and I hope it's useful to people with lived and living experience who are directly impacted by involvement in the justice system. Let's take a moment to acknowledge the different perspectives and experiences that participants will bring to the forum today, and be respectful of these as we engage with one another via chat and Q&A. I will now turn it over to Sudha Sabanadisam for an overview of the project. Sudha is the lead policy analyst for substance use at the Canadian Mental Health Association, Ontario Division, and the project lead.
Thank you, Trevor, and thank you for the opening remarks. Before I start my presentation, I would like to make an announcement. Let me just put up a slide here. So the announcement is people with lived experience of substance use and involvement in the justice system will be provided with honoraria for participating in the Knowledge Exchange Forum today. Please send me an email at the address on the slide, and we can arrange for the honorarium. I will also post my email address in chat so that you can copy it from there. So please do connect with me. So it is my pleasure to provide a brief overview of the project and introduce the project team. I will be joined by my colleague, Candice Vena, shortly. So the Cannabis and Drug Treatment Code Research Project began in the fall of 2020. We are scheduled to complete the work in December of this year. This project is truly a collaboration between the Canadian Mental Health Association Ontario Division, John Howard Society of Ontario, and the Provincial Human Services and Justice Coordinating Committee. The academic advisor for the research is Dr. Akwasi Owusu-Bempah, who we will hear from later this morning. I want to take this opportunity to thank the Mental Health Commission of Canada for funding the project. This is one of the projects funded by the Mental Health Commission to address knowledge gaps in the relationship between mental health and cannabis among priority populations. Today, the research team will be sharing for the first time results of the community-based research, which focused on the impact of cannabis use and participation in drug treatment code programs. The perceptions and practices of service providers who support drug treatment code participants was also a focus of the research. I would like to take a moment to talk about cannabis. With the legalization of cannabis in 2018, we are now in a better position to study the impact of cannabis use in the community, learning about both the harms and benefits of cannabis and how it is being consumed among diverse groups and communities is essential for updating policies and amending regulations. Understanding the use of cannabis among people who have been impacted by drug policies and stigma associated with drug use is most important in this case. For this project, the focus is on learning from people with lived experience of involvement in drug treatment code programs and the criminal justice system. Although cannabis was legalized in Canada in 2018, attitudes, practices, and policies at the community and systems levels are still evolving. This is not surprising since cannabis use was prohibited for 95 years prior to legalization. This project attempts to understand how legalization of cannabis may impact potential policy changes within the justice system. With that note, I would like to turn it over to Candice Vena, who will provide background on drug treatment codes and the impetus for the research question. Candice is the Director of Justice Policy at the Canadian Mental Health Association. She oversees the Provincial Human Services and Justice Coordinating Committee. Candice and her team are part of the project team. And with that, over to you, Candice.
Thanks so much, Sudha, and good morning, everyone. And it's my pleasure to be here today and provide you a little bit of background. First of all, on the Human Services and Justice Coordinating Committee. I'm sure many of you that are joining today may be familiar, but for those who don't, I think it's really important to preface this by grounding where the HSJCC falls within this work. So the HSJCC network is made up of a voluntary collaboration of professionals that are working in the human service and justice sectors who are really coming together to break down silos between systems and affect better outcomes for our priority populations of clients who have complex needs and are involved in the justice system. We have committees across the province at the local, regional, and provincial level. And all of these collaborations are a great example of how coming together really helps to affect meaningful system change. We have one provincial committee who is a partner in this project, which is why it was so important to partner with the HSJCC, really to leverage that wide experience and expertise of stakeholders that are working in drug treatment courts and have intersections across the province. The provincial HSJCC is our provincial planning body that help directs system change initiatives across Ontario and is made up of representatives from those regional HSJCCs, as well as our ministry partners and other provincial stakeholders with a variety of expertise in human services and justice. I do want to take a minute to note an advisory committee that helped guide the direction of this work from early days in 2020. Many individuals within the HSJCC network were a part of this. And I'd like to thank you for those that are on the call today that are part of the advisory committee for your time and expertise in this project. Many of our members, as I mentioned, are also working in drug treatment courts across the province. So we have crowns, judges, lawyers, duty counsel, treatment providers, and those with actual lived experience of drug treatment courts that are joining us today, which is so great to see. Many of them convene to identify key challenges and share best practices across the province. If I could ask Sudha to go to the next slide, please. Great. So just as a little background, and I'm sure many of you are familiar with drug treatment courts and why you're here today, but for those that aren't, what are drug treatment courts? So they are a model of intervention that were designed to provide support who have problematic relationships with substance use and have contributed to the reason that they've become involved in justice system in the first place. We refer to them as DTCs for short, and they fall under the umbrella of what we call problem-solving courts, therapeutic courts, or wellness courts. And they serve a very similar purpose to mental health courts in Ontario. And in fact, many of them are under one umbrella in some of the areas of the province. DTCs really fall under the principle of therapeutic jurisprudence. For those who are not familiar, it really considers the impact of the law on the emotional well-being of a person and recognizes personal dignity of all individuals and seeks fairness and social justice by looking at alternative ways of attempting to resolve this problematic issue. Therapeutic jurisprudence attempts to ensure that the criminal justice approach is therapeutic in nature, which we know is not necessarily the case all the time, rehabilitative, and reduces recidivism by addressing those underlying issues. DTC programs are a way to serve as alternatives to incarceration and may involve a number of community-based treatment services along with judicial supervision. And just a note that will be helpful as we move into the project results later on, in Ontario, drug treatment courts are not all unified in their approach to cannabis consumption and whether it is permitted or not allowed in the program during participation. The next slide, please. So if we look back to 2019 and really see where we've come in terms of the HSJCC's work, as well as CMHA Ontario, which led to this partnership with the Mental Health Commission on cannabis, CMHA Ontario conducted a survey across the province with, at the time, what was 14 drug treatment courts. Of course, we know those numbers are changing over time. I believe in 2019, there were 2 courts that were close to operation. They were in the initial phases during that time, as well as there were 2 on hold. And of course, during the pandemic, things have changed as well due to issues with limited resourcing, funding, and obviously moving over to virtual courts. But at this time, a number of identified operational challenges were mentioned in our scan, and this is just a snapshot of what we heard. So one of the challenges is funding. So reliable, consistent funding for the program across the province. Some courts don't have funding at all. Differing approaches and best practices, especially with clinical services and how we approach drug treatment court programming among staff support and court staff. There are a number of logistical challenges that come up, including finding court space and having transportation, a number of staffing challenges, so changes in partners, that can create inconsistencies and pose challenges in building those relationships. Also, accessing community supports for specific populations. So in particular, to us LGBTQ plus populations, and as well as Indigenous populations and those who have brain injuries, dual diagnosis, or fetal alcohol spectrum disorder. As well as there's been some difficulties in accessing support in the community, and which we all know housing is top of mind, so access to housing and withdrawal management services. Another challenge that came up across the courts is determining whether psychoactive substances should be permitted, and that includes prescription benzodiazepines, but also both medical and recreational cannabis were noted as part of this. So that's just a little background of what we know about drug treatment courts since 2019. Of course, as I said, much has evolved during the pandemic, and this project really is focused on looking at the impact of cannabis use. So I'm going to turn it back over to my colleague Suda to talk about where we're at now.
Thank you, Candice. The conversations we have today and information shared by the speakers will be part of the learnings of the project and will feed into the key findings of the research project. We are holding a small group policy discussion as well on drug treatment code programs, which will also inform the final report for the project. I'm happy to let you know that we'll be sharing our findings through different channels, including a final report for the Mental Health Commission. And it is my understanding that the Commission will be using the information from this project and other community-based projects on cannabis and mental health to inform their response for the review of the Cannabis Act that is currently in progress. And before I pass it on to the next speaker, I would like to introduce the project team. We have with us for the project team, people, it's, as I mentioned, it's a partnership. And first and foremost, I want to mention and introduce Trevor Timchuk, who opened the forum today, and Nicoletta Curson, who will be also speaking later this morning, and our academic advisor, Dr. Akwasi of Sabempa. And from the John Howard Society, we have Reza Ahmed, the Director of Policy and Research, and Megan Costa, who is the lead researcher for the project and also is a research and evaluation specialist at John Howard Society. And from CMHA Ontario, Sean Cherry, who's the interim director for public policy, and myself. And from the Provincial Human Services and Justice Coordinating Committee, we heard from Candice Vena, who is the Justice Policy Director, Erin Pickett, and Tasha Rennie, who is behind the scenes providing all of the technical support at the moment. So thank you to the team. Let me just stop sharing this. So at this point, I would like to introduce Megan Costa and Nicoletta Person. It is my pleasure to introduce Megan, who is a research and evaluation specialist at the John Howard Society of Ontario and the research lead for the project. Megan will be walking us through the research results today and the community-based research process. Nicoletta is a project consultant for this project and is also a peer researcher with the Justice and Equity Lab at St. Michael's Hospital. Megan and Nicoletta will be presenting, and if you have questions for them, please send them to us in the Q&A box, and we will respond during, or they will respond during the discussion period of the forum. Thank you, and over to you, Megan.
Thanks, Suda. I'm just going to share my screen. Give me one moment. Okay, so good morning, everyone. As mentioned, my name is Megan Costa, and I'm a research and evaluation specialist with the John Howard Society of Ontario, and I've worked as a lead researcher on this project since it began in October 2020. I just wanted to begin by saying thank you so much for taking the time to be here today and for being a part of the forum. I will begin by going through our methodology, some challenges that we faced throughout the project, and then our data collection tools that we used. I will then be turning it over to our peer researcher, Nicoletta, who will be providing her experience with collecting data at the Toronto Drug Treatment Court Program during the COVID-19 pandemic. Following this, I will provide an overview of the research results. So this project was largely informed by community-based research, which is a research approach involving active participation of relevant stakeholders and individuals' lived experience in the issue being studied throughout all phases of the project to ensure that the research is producing useful results that contribute to positive change. So as mentioned, for our research team, we had our core research team, which included the Canadian Mental Health Association, John Howard Society of Ontario, the Provincial HSJCC, our academic advisor, and most importantly, our individuals with lived experience providing their expertise. We also put together a project advisory committee made up of diverse organizations and a drug treatment court champions team, which I will go into further detail about on the next few slides. As Suda had mentioned, our research focus was to look at the impact that cannabis use has on client participation in drug treatment court programs. To answer this question, our project used a mixed methods approach, meaning that we collected both qualitative and quantitative data. In order to collect this data, we followed two separate but connected streams, which were clients of drug treatment court programs and service providers working within drug treatment courts. Our original intention was to learn more about clients and service providers through surveys and focus groups. However, we quickly realized that because of COVID-19, we would have to readjust our original strategy. We had initially proposed a sample size of 5 client participants and 5 service providers per drug treatment court program for a total of 70 client participants and 70 service providers across Ontario. However, with the pandemic, many courts were not functional, and those that were operating at the time had few to no clients. In addition to low operational numbers, the research team had to account for other challenges, which I will also talk about in further detail over the next few minutes. To account for the many challenges that we faced, the research team decided to instead recruit as many eligible clients as possible, rather than just having 5 clients per drug treatment court program. For the client participants, we conducted a longitudinal study through a series of surveys to measure change over time using pre and post tests. Using random sampling, client participants were recruited to take part in the pre-survey, which was administered at the start, and then we asked clients to participate in the post surveys, which were administered at 3-month intervals for a total of 1 year, or 4 surveys in total. Client surveys requested demographic information, as well as information about clients' cannabis use currently and over their lifespan, previous criminal justice involvement, reasons for consumption, their preferred mode of consumption, and pre-existing or new mental health and substance use issues. We also asked questions regarding their perceived mental health and the services they had been able to access for support. After the surveys, participants were invited to take part in one-to-one interviews, which collected qualitative data in order to supplement the data from the surveys. For service providers, surveys were administered once and requested information on their perspectives and learnings on the relationship between cannabis and mental health, their experiences providing support to clients who use and do not use cannabis, and the principles that inform their current practice and service delivery. Similarly, after the surveys, participants were invited to take part in one-to-one interviews. Before I go into the data collection tools that we implemented throughout this project, I think it's important to situate us in what was happening at the time that we received funding. It was October 2020, and we were in the second wave of the pandemic, right before the province introduced the color-coded response framework. At that time, areas such as Toronto, Peel, and Ottawa saw further restrictions as they were deemed hotspots. Many services were being run virtually, including courts and community programming. This research was never intended to be conducted virtually. However, with the uncertainty of where the pandemic was going, we knew we had to make adjustments to our initial plan. Looking back, we really did hit the ground running to establish our core research team and our advisory committee. We also immediately began developing tools and updating the environmental scan by reaching out to drug treatment courts to find out which courts and court programs were operational at that time. The core team met weekly within the first few months to address any challenges and find ways to mitigate them. Some of these challenges included COVID-19 impacting the operation of drug treatment courts, having services being provided remotely, and little to no active clients in many programs. With our advisory committee, we also discussed issues around sample sizes, engaging and sustaining engagement with participants, especially for those who do not have access to a telephone or a computer. In order to address some of these issues, we changed our eligibility criteria and sample size numbers to allow for more clients to participate. Initially, we had planned to only include participants who identified as cannabis users that were beginning the drug treatment court program. However, instead, we decided to include non-cannabis users and individuals who are at any stage of the drug treatment court program, so long as that they were still active in the program. By allowing non-cannabis users, we were able to capture any individuals who did begin to use cannabis over time, perhaps as a harm reduction tool. Also, we opened our sample size to include as many clients as possible to account for attrition over time, especially if we were unable to sustain our engagement with a client or if the client dropped out of the program. To address engagement with clients more specifically, we created a plan to engage with clients in various ways to address technological and accessibility barriers. We also changed our initial plan, which was to conduct focus groups. Instead, we decided that conducting one-to-one interviews would be much better, as we learned it would be easier to be more flexible with individual schedules during this time for both clients and service providers. Between November and December 2020, we finalized our data collection tools based on feedback from our advisory committee and academic advisor. We also submitted a Research Ethics Board application to the John Howard Society of Ontario's Internal Research Ethics Board. Also, through the funding from the Mental Health Commission of Canada, 2 of our core team members were also invited to take part in workshops with the Centre for Community-Based Research between November 2020 and April 2021. This provided us with the opportunity to talk with other teams that were also awarded funding and work through the challenges that we were experiencing based off of their expertise. At this time, we were continuing to be faced with the challenge of our sample size, recruitment methods, and how to sustain engagement. Our initial plan for recruitment was to use the existing supports we had through a connection within each drug treatment court to see if they would be able to support us in recruiting both client and service provider participants. However, with many of the programs not operating, we were unsure if recruitment would even be possible. Based off of discussions with our advisory team in the fall of 2020, we decided in early 2021 that it would be best to put together what we call the Drug Treatment Court Champions Team, which were individuals who would be our key contact at each drug treatment court program to support client recruitment and service provider recruitment, and also share information about the project. We began reaching out to drug treatment court programs and putting together our team with about 1 or 2 contacts at each location. As we were unable to collect data in person as we had originally planned, we now needed to also ask our champions to administer our data collection tools. Understandably, many program staff indicated that they may not have the capacity to support the research project in this way at that time. By February 2021, we needed to address feedback from the Research Ethics Board to ensure that all of our data collection tools adhered to COVID-19 guidelines and that there were supports in place for participants. This included having multiple methods for data collection, which I will go into further shortly. In March 2021, we decided to take the opportunity to have one-on-one coaching with the team at the Center for Community-Based Research. During this meeting, we were advised that as our drug treatment court champions would be doing more than participant, would now need to train individuals in data collection as they would be part of our research team. In April 2021, we met with our DTC champions team to provide an information session which were put together in virtual and paper formats. Over the next few weeks, we engaged in follow-up meetings with DTC champions around operational and capacity challenges that I previously mentioned. We provided one-on-one information sessions and asked if there were any ways the research team could support champions at that time. Though the team was successful in recruiting champions, some programs still did not have any clients. However, we were told that some expected that they would have more clients joining following the third wave of the pandemic. Around the same time, we were told that there were approximately 60 clients across Ontario and that not all clients would be able to participate. Additionally, some DTC champions advised against recruiting clients to participate, as the surveys did ask information about client substance use. For those programs that take an abstinence-based approach, this would ask clients to discuss substance use when they are not permitted to do so. As well, this was the case for some programs that take a harm reduction approach, as many require abstinence from all substances in order to successfully graduate. Despite some concerns, many champions shared that they would support the research and recruit clients if they were able to do so. By May 2021, we began administering both the client pre-survey and the service provider survey. Though our proposed plan was to assess participants at one time and follow their progress over a year, we had to adapt and allow participants to complete surveys whenever they were recruited and begin the survey process from there. Most of the client pre-surveys were completed between May 2021 to August 2021. However, a few participants did join in the fall and winter months. Though we had intended to engage with clients all over Ontario, we had limited success and were only able to engage with clients from the Toronto Drug Treatment Court program. We were very fortunate as we had a member from our core team, Nicoletta, that could support our Toronto champion and the clients in person throughout the survey process. By December, we were still not successful in connecting with clients from other drug treatment court programs in Ontario, and we did have that lower number than anticipated for client participants. At this time, we began to develop an interview guide that we would use to connect with individuals who did not participate in the survey process. This would now allow us to talk to clients outside of the Toronto program and hear about their experiences at their drug treatment court program. After resubmitting our research ethics application and receiving approval in May 2022, we immediately began recruiting participants for one-to-one interviews. So I'm just going to go through a few details about our data collection tools that we use through our DTC Champions package. So each client tools package that was provided to the champions included a reference package with a communications guide outlining the role and responsibilities of the champions and recruitment posters to share with both clients and service providers. To deliver tools to clients, we provided 3 methods, including a virtual method through email, a paper copy sent to the client's address, and a paper copy which could be picked up curbside at the DTC location. However, the method that actually ended up being used was using a paper copy in person at the Toronto Drug Treatment Court program. Both the online and paper packages were relatively similar and included a consent form, a consent video link on YouTube to walk clients through the form, a debrief form with resources in the event that clients felt distressed, a copy of the survey or survey link, and an honorarium. As well, we included a support form which provided participants with 3 different options if they required additional support to fill out the surveys. In the service provider tools package, we included a recruitment poster and a survey link, most of which was shared through email. And as mentioned, we also began conducting interviews earlier this year with both client participants and service providers with the assistance of our Drug Treatment Court Champions team. So I'm now going to pass it over to Nicoletta, who will talk a bit about her experience providing support on the ground.
Hi, thank you all for attending. As you heard, I'm a peer researcher and a project consultant of the study. I am also a former client and a graduate of the Toronto DTC program. So that was very helpful with connecting with clients. Our DTC champion was amazing. She helped both with participant recruitment, sustained engagement, and retention from the first and fourth survey. COVID definitely changed how we were able to connect and engage with study participants. So initially, we had intended to do online surveys, as Megan mentioned. We ended up doing paper surveys. Some of that was done at the CAMH location when clients would come into CAMH. And we found other workarounds for clients that were not able to attend at the location. We worked closely with the DTC therapists as well as the DTC champions. So some of that looked like going to housing, the locked housing that partners with the DTC program, and then either meeting in a park due to COVID, giving them the survey, having them go home or to a location of their choice to fill it out, and then waiting for them to fill it out and then picking it up from them. And so that was one of the ways that we were able to meet during COVID. So a lot of that happened outside. Also, there was a period of time due to COVID that a lot of the clients or some of the clients were experiencing personal issues. It was an adjustment period for everyone, certainly both program staff and the clients as well. And so there were also, as Megan touched on, tech accessibility issues. So our champion and team at the DTC was able to provide either tech if necessary, to also get us in touch with them in case they didn't have phones. Also, I remember going there. There are groups that occur 3 times a week for the men's group, and then I would go during those hours. Also, due to COVID, I'm sure as everyone here knows, court moved to virtual. So that there was a lot of disruption, not only to the program, to the clients in the program, until everybody figured out what that's going to look like, how often. It was a big shift from twice a week to once a month. And so I remember when virtual court started happening again, as a lot of the clients don't have access to their own devices that are consistent and reliable. They were also coming into CAMH to engage with the court team virtually. So I was there, sometimes 4 times a week, trying to see which clients were there that day, in order to get them to participate in the surveys, especially over a sustained period of time. And they were also fantastic about it. Our DTC champion really was engaged with the study and connected with the clients and their therapists on a regular basis to see who would be around and letting them know when the next survey would be taking place. So we have a really great retention rate, 75% from the first to the fourth survey, which is amazing. So yeah, also the staff was really helpful. The ones who weren't the champions on the study, they also connected with our champion from the program and were able to touch base when their clients called in, the ones who didn't have access to devices or who weren't coming into the location during COVID. Again, there were also the home visits, so organizing that with our champion at the program and the therapist was really key to getting all the data collection. So later, as we moved into the second survey, the third survey, there was a lot of both COVID burnout, a lot of Zoom burnout. I remember some of the other courts, they were suggesting that maybe they would become operational soon. And though that took longer to happen than anybody anticipated, including them, due to all the COVID waves. So yeah, but I remember that period. It was really difficult to just, everybody was on Zoom meetings all the time. And I think there was a lot of burnout with that. So the fact that we were able to be at the location at CAMH, whether at some points inside, at some points outside, depending on the COVID situation, that was really great, I think, both for engagement and for having people really remain interested in working with us on the study. So I just really am so grateful to everyone on the team and our DTC champion, as well as all the lovely participants who were part of the research and provided such rich data. So that's my experience of data collection during COVID at the Toronto location. Thank you.
Thanks so much, Nicoletta. So as we are still in process of collecting data for the client interviews, I will just be providing a high-level overview of the survey results from the 4 surveys. In total, all client surveys were completed, as Nicoletta mentioned, by pencil and paper at the Toronto Drug Treatment Court program, and we had an overall retention rate of about 78% from the first survey to the last. We found that almost all participants were male between the ages of 36 and 55. About 2/3 of the participants identified as white, while other respondents identified as Indigenous, Black, East Asian, and Southeast Asian. About 75% of the participants shared that their highest level of education was some high school or a high school diploma or GED. Similarly, over 70% of participants shared that their current employment status was income support or unemployed and unable to work. In terms of being involved with the Drug Treatment Court program, the most common way that clients were referred into the program was by a court worker or through self-referral. In terms of criminal justice involvement, over 80% shared that their first interaction with police was when they were 25 years of age or younger. Similarly, 75% shared that they were 25 years of age or younger when they were first charged. The most common crimes that participants shared that they had been convicted of was theft under $5,000, administrative offenses, including failure to comply and failure to appear, and drug possession. When asked about the substances that respondents had ever used, the most identified substances was cannabis, alcohol, crack, and cocaine, with most identifying that they had first tried these substances at age 18 or younger. More specifically, when asked about the frequency with which individuals use substances before their current conviction, the common substances being used daily were crack, cannabis, and fentanyl. Throughout the surveys, more than 60% of participants shared that they had received treatment for their substance use, including residential treatment centers, addiction treatments, and programming through the Drug Treatment Court program. Participants shared several reasons that acted as their primary motivating factors for substance use, including but not limited to coping with trauma, dealing with grief and stress, to treat mental health issues, and boredom and loneliness. Participants also shared that loneliness, isolation, and boredom during the pandemic led to individuals using substances more often. In terms of cannabis use more specifically, nearly all individuals identified using cannabis when starting the survey process. However, by the end, about 70% were continuing to consume cannabis. The average amount of cannabis used by participants on a typical day was 2 grams or less when the survey started, but over time, the amount of cannabis use declined to none or almost none. Participants commonly obtain their cannabis products from a friend, from a dealer, and from a legal storefront. However, they were less likely to receive cannabis from a dealer by the end of the survey. The most common reasons for consuming cannabis throughout the surveys was to reduce anxiety, to treat anxiety, to assist with sleep and relaxation, and as a tool for stress relief. Participants were more likely to use cannabis alone than with others, especially every day or almost every day. Over time, participants were more likely to say that they never use cannabis with others. When asked about participants' opinion on how cannabis impacts them, most shared that it had a somewhat positive or positive impact on their overall well-being and mental health. However, they shared that it did have a somewhat negative or negative impact on their education and employment. In terms of mental health, individuals were asked if they had any mental health conditions and whether they were formally diagnosed or not. Most individuals with a formal diagnosis specified that they had an addiction or substance use disorder, while those with no formal diagnosis identified having anxiety and depression. These mental health conditions remained consistent throughout the survey process. When asked if cannabis use affects their mental health, participants were more likely, especially over time, to share that their mental health did not worsen at all, and that their mental health improved sometimes or often. So now we will be going through an overview of our engagements with service providers through the surveys and interviews. The service provider survey was first administered in June 2021 and closed August 2021. And there were a total of 15 service provider participants. Service provider interviews took place beginning in May 2022, with a total of 5 interviews conducted to date. Overall, almost all participants were female, and participants came from a number of different drug treatment court programs, coming from various roles such as program managers, Crown attorneys, caseworkers, social workers, judges, and many more. Through surveys, participants identified a range of 0 to 50 clients, with most serving about 1 to 4 clients per week. When asked about the most served demographic group in their program, most survey respondents identified white males between the ages of 30 to 50. For interview respondents, this varied, with many sharing that they actually had a fair number of females in their program, some even with more females than males, and individuals between the ages of 25 to 50. Though both the survey and interviews, through both the surveys and interviews, when asked about the client approach that their DTC program takes, there were programs that took an abstinence-based approach, a harm reduction approach, an approach that used both aspects of abstinence and harm reduction. Those that use both approaches explain that the ultimate goal of the program is abstinence and that there is a requirement of 90 days sobriety prior to graduation. However, these respondents shared that they support clients where they are in their journey to recovery, as full abstinence can be harmful to clients when they begin the program. For the programs that take an abstinence-based approach, almost all provide support to clients who may be experiencing withdrawal symptoms. Respondents were asked about predominant substances that their clients were using. According to survey respondents, the predominant substances used by clients are fentanyl, methamphetamines, and cocaine. Interview participants shared similar substances. However, they also shared that almost all of their clients use cannabis. Through both surveys and interviews, many shared that cannabis is beneficial as a form of harm reduction, as it can be used to curb cravings for other substances, manage pain, and reduce anxiety. Respondents indicated that the long-term effects of cannabis use might be harmful to an individual's physical and mental health, and that any use that interferes with an individual's daily life can be problematic. Through interviews, participants shared that smoking can pose a particular harm, but shared that there are other options for this, such as edibles. Through both surveys and interviews, the most frequent reasons as to why participants do not complete or graduate the program were non-compliance in the program, dishonesty, and reoffending. A few respondents explained that it can also be a combination of a lack of engagement and progress. Respondents shared that some of the successes they have seen in the program are that individuals are making changes in their lives, they're reconnecting with family, gaining employment, finding stable housing, and having some stability. In terms of challenges, respondents shared that they have a lack of resources, a lack of funding, and they experience clients relapsing. These challenges were exacerbated by the COVID-19 pandemic as it impacted the operation of the drug treatment courts and the drug treatment court program and posed various accessibility and engagement barriers for clients. So this is just a high-level overview of the data that we've collected to date. However, as Sudha mentioned, the full details and some knowledge dissemination tools will be provided probably next year, early next year. But yeah, if you have any questions, please do put them in the chat and we can answer them during the moderated Q&A discussion following the panel discussion. Thank you so much.
Thank you, Megan and Nicoletta. That was a fantastic overview of the results of the project, and thank you for that. And next in the agenda, we have our keynote speaker. It is my pleasure to introduce Dr. Akwasi Obasubampa. Akwasi is the academic advisor for the project. He's a professor in the Department of Sociology at the University of Toronto and chair of the governing board of Massey College. Akwasi's academic work has examined the racialized nature of drug law enforcement in North America. He is currently exploring how drug legalization is being used as a means to redress the various harms caused by drug prohibition. He's the author of the book, Waiting to Inhale, Cannabis Legalization and the Fight for Racial Justice. Over to you, Akwasi.
Sudha, thank you very much. And I just want to confirm, you can give me a thumbs up that everyone can hear me.
Perfect.
Wonderful. That's great. So again, thank you for the introduction and the invitation, not only to provide this keynote today, but also to engage as the academic research advisor on this project. I was very pleased when I was initially asked to join, and it's been a pleasure to engage here. So as noted, I am an academic. I'm a professor at the University of Toronto, and I do a fair bit of work in this space, just in terms of conflicts of interest. My research has been funded by Social Sciences and Humanities Research Council and the Canadian Institute for Health Research, as well as directly by other federal agencies and arm's length federal bodies. I've also engaged in consulting work in the private sector with cannabis companies and companies in the emerging psychedelic space. None of that work and none of that funding or consulting engagements has informed the talk that I'm giving today, or my engagement with the research project here. So as noted from my background, I am a criminologist by training, and I teach in a sociology department. Much of my work focuses on the intersections of race and the criminal justice system. And as I'm sure many of you well know, you can't study in a serious way anyway, or understand how members of different racial groups interact with the justice system, the police, courts, and corrections without, of course, looking at drugs and thinking about the way in which drug policy influences the criminalization of, racialized groups in particular. In the Canadian context, we can think about Indigenous populations. We can think about Black populations being disproportionately subject to police detention, arrest, and ultimately conviction for drug-related crimes. But our marginalized groups generally, I was quoted last week, and I often say it, that I consider cannabis to be a gateway drug, not in the way that people typically think of it, as a gateway to harder drug use necessarily, but as a gateway into the criminal justice system for our most marginalized populations. And that's a lot of what my work has focused on for the last certainly 5 years and almost a decade now. I think it's very interesting to be having the conversation that we're having today around drug treatment courts, and to be in the both mental health and drug policy space at this point in time. I'm sure some of you, if not all of you, have been paying attention to the pretty significant policy shifts that we're seeing around drugs and drug users. And certainly from my perspective and in the nature, in the context of the work that I do, an increasing recognition of the failure of the war on drugs to, achieve its stated goals, which were to reduce, the supply and the use of drugs. And I think these policy shifts are driven not only by a recognition of the failures of the war on drugs, but also, of course, the horrors caused by a toxic drug supply and the opioid epidemic. 4 years ago, of course, in Canada, we federally legalized cannabis. And I think many of us who are watching this very closely are pleased that despite the Chicken Littles of the world crying that the sky was going to fall, it has not, in fact, fallen. The available data show that rates of cannabis use have not skyrocketed, at least in the short period of time since legalization. That impaired driving is not up, although it perhaps is being detected a little more. I think at this point in time, the major concern are coming from people who are actually operating within the cannabis industry, who, as we've been hearing over the past week, quite vocally are struggling to make ends meet in their businesses. But certainly, from my standpoint, and I'll get this out, right off the bat, I'm in full support of kind of broad drug legalization, not decriminalization, but legalization. I believe that drugs, not only cannabis, but beyond, through psychedelics and into what have often been considered more dangerous and scheduled more harshly drugs, including heroin, cocaine, and methamphetamines, should also be regulated and perhaps tightly regulated, the more harmful they may be to individuals and to society, but that we should remove the criminal element from the large-scale production and importing of these types of substances and move that into the purview of the government so that people who do use drugs can have access to a safer supply of drugs and do so in ways that does not fuel the crime and the violence that that comes alongside illegal drug markets. So we're in this situation now, of course, where not only do we have cannabis legalized in Canada, British Columbia has recently decriminalized possession of small amounts of certain drugs. The city of Toronto has also applied to the federal government to decriminalize a broader array of drugs. We know that, and again, related to some of the work I do in the psychedelic space, that our government is currently grappling with the provision of psychedelics, the giving of psychedelics to people who could use them, namely at the moment, people who are terminally ill, suffering from end-of-life distress, for whom there's evidence that psilocybin can provide some relief. And so our government thinking about this at the moment. President Biden in the United States, of course, just announced the clearing of federal cannabis possession records and signaling that the DEA will likely provide psychedelic drugs or approve psychedelic drugs for therapies within the coming years. And he's directed governors to clear criminal records as he had, and his government also to look at the scheduling of cannabis. So that's, when we look south of the border, I commented that I don't think we're going to see a significant change based on these announcements in the United States. But when we think about this in a broader context, the huge ship that is the U.S. drug policy is beginning to be steered in another direction. And I think that in and of itself is very significant. The Economist newspaper this week, longer proponent of more sensible drug laws, also had two features on the legalization of cocaine in Central and Southern America. Again, acknowledging that the war on drugs, largely born out of the West and then exported to other countries, born out of North America and exported to other countries, is not meeting its stated aims. And in fact, it is, again, fueling, not only crime, but large amounts of violence and reaping devastation in many countries who produce drugs like cocaine to be shipped to the consuming countries like the United States. So clearly things are changing, at least in parts of the West, with respect to our approach to drugs and the people who use them. Now, from my perspective, I think this change has been in the works for a long time. It comes on the heels, of course, of several important social shifts. So one, as a criminologist, I've been observing is a move away from quite punitive criminal justice policies And although this is, of course, not universal, and I think about how harsh our punishments are and our approach to marginalized people and our approach to crime as swinging on a pendulum that often goes back and forth between harshness and less harshness, there was certainly throughout the 1980s and into the 1990s, a push for harsher and harsher and more punitive approaches to law enforcement and approaches to punishment. And I just mentioned that Joe Biden has promised to clear the records, or has cleared the records of federal cannabis possession records. But he, of course, was also responsible for one of the most punitive crime bills in American history, the 1994 crime bill, right? So we're seeing that, harsh approaches to dealing with crime and disorder don't work. In fact, they can actually be counterproductive. And alongside that, of course, was the murder of George Floyd in 2020, which has spurred a racial reckoning, not only in the United States, but beyond. And as I noted when I started speaking, my work in the area of drug policy is focused mainly on how our drug laws were both developed and then have been implemented in a way that really serves as an effective means of racial social control that effectively can be used to target and then criminalize and then, of course, subjugate racialized populations. Here in Canada, for those that don't know, our first drug laws, really, alcohol prohibition was targeted only at our Indigenous population. So initially, alcohol prohibition did not apply to white people in the country. There were racial differences in how prohibition of alcohol was enforced. Our Opium Act of 1908 was developed largely to deal with what was seen as a Chinese problem on the west coast of Canada. Large numbers of Chinese people had been recruited to Canada to build the Canadian Pacific Railroad, and upon its completion, they were competition for white labor, and that, of course, scared many people. And so our 1908, Opium Act was devised largely as a way of controlling, because the connection between Chinese people and opium smoking was drawn, largely to subjugate and to criminalize that population. And we saw that extending not only south of the border, but also to other drugs as well. And when we look at the American situation, it's quite similar. First was the criminalization of opium, again, out of concern around Chinese and other Asian populations. From there, we saw the criminalization of marijuana, based largely on fears of Mexican immigrants coming in following the revolution through the southern border in Canada. Emily Murphy's credited with creating fear of racialized cannabis users, one of the most prominent kind of proponents of such an approach. And again, if we move south of the border, the connection between, for example, Black people and jazz music and cocaine. And so our drug laws have always been very heavily racialized. And we see this, certainly in terms of how they're enforced, right? We continue to see that despite the fact that self-report surveys show that drug use is relatively similar across racial groups, our arrest statistics paint a very, very different picture. We see very clear evidence of racism in drug law enforcement. And there are, of course, some differences. We know that, for example, Indigenous people who live in urban areas, Black people in urban areas are more likely to live in heavily concentrated areas. Our Black population in a city like Toronto, for example, more likely to live in multifamily residences and in apartment buildings. And so young people, for example, might be pushed out into the streets to consume something like cannabis prior to prohibition in a way that more privileged suburban young people might not have. And so there are different levels of police surveillance that are applied, both based on race, but also, again, based on who is out in the streets and who are using those substances. But that aside, again, we know that there is racialized targeting for drug law enforcement. And so this was my entry point into the world of drug policy, and it certainly expanded from there. I will say, going back even before I was studying drug policy in a serious way, one of my most memorable experiences as an undergraduate student came in terms of considering the intersections of drug use and criminal justice came when I was researching the profile of people in federal prisons in Canada. Now, this was early on in my career, and I wanted to understand the backgrounds of those who are caught up in our federal system. Who is it that comprised what Canada considered to be its most serious and its most dangerous offenders? Who were they, and what kinds of offenses had they committed? And what I learned then, and will perhaps be of no surprise to many of you, was that upwards of 80% of the federal correctional population were flagged as having substance use and abuse and mental health issues. Right, the vast majority of people behind bars had some combination of mental health flag as well as substance use or abuse flag. And a significant proportion of those indicating that their substance use had been or misuse had been a contributing factor in their offending. And this was I was certainly not naive to drugs or drug use. It had been around me in many places that I had lived and I'd grown up, and I certainly had an interest, a personal interest in drugs. But again, in thinking about these most serious, I use the term offenders as the language of our correctional system. Prisoners as a term that I prefer. Thinking about the backgrounds of these individuals, again, who had been caught up and acknowledging, as I had been taught, that many of them had experienced trauma early in life, that they had various forms of instability, perhaps exposures to the child welfare system, estrangement from family, and marginalization more generally in our society. This nexus, of course, made perfect sense. In retrospect, it was pretty simple stuff, right? Yet too many people in our society, I think, continue to fail to recognize this reality. Now, of course, problem-solving courts generally and drug treatment courts in particular have been developed to address this very link, right? The drug treatment court is a relatively modern invention, and it's one that's been designed to provide treatment for individuals who have a problematic or deemed problematic relationship with substances, and this has contributed to their involvement with the justice system. And they come under this broader umbrella of problem-solving courts, and I think that problem-solving courts have an important place within our justice system. They can often involve community-based treatment services in conjunction, of course, with what would be called judicial or criminal justice supervision. And it's based on the underlying principles of therapeutic justice, considering the impact of the law on the emotional life and the psychological well-being of individuals, and recognizing them as people and trying to instill a measure of dignity into the process. There have been a number of studies on and a vast, semi-vast evaluation literature on drug treatment courts, and there's evidence, to support problem-solving courts generally and drug treatment courts in particular, with respect to lower rates of recidivism and decreased substance use and less criminal activity for those who are members of the system. And for people who are interested, Canada's federal drug treatment court funding program was evaluated I think that last major evaluation report I found from 2015, and it is quite comprehensive. It's certainly worth a read for those who are interested. There's a much larger body of research emanating from the United States, finding again decreases in recidivism and substance use and criminal activity for drug treatment court clients, along with, of course, economic benefits. And we've seen similar results in the Canadian context as well. And so there's certainly a place and signs of promise for drug treatment courts, but they have also been critiqued as well, right? Critiqued for a number of different reasons. There's arguments that they may be net widening and they would bring people through the formal criminal justice system, and especially because they typically take less serious offenders in ways that might not if they didn't exist otherwise. For someone like myself, who's immensely interested in the intersections of race and the justice system, certainly evidence to suggest that they don't perhaps serve members of different racial groups in the same way, or serve them, period. And so as we heard Megan discuss in presenting some of the findings, that men but certainly white people may benefit more from drug treatment courts than members of other racialized groups. And in the 2015 evaluation of Canadian DTCs, there were recommendations that flexibility in program options, including incentives and sanctions, may be useful in better attracting and achieving positive results with Indigenous and racialized population, as well as with women and with youth. And so I think certainly there's a need, as we're seeing kind of more generally in the criminal justice system, to more culturally relevant and culturally tailored treatment options. And these would be more, if we're thinking about a kind of needs responsivity model within the justice system, maybe more appropriate to meet the needs of the diverse people who come into contact with the system. And again, acknowledging some of the work that I've done, demonstrating these clear racial differences in drug-related arrests, and seeing those kind of in other areas as well. There is a clear need to ensure that drug treatment courts, as with other problem-solving courts and approaches in the criminal justice system generally, meet the needs of the diverse Canadian population. There are, of course, questions raised about drug treatment courts centering on or models that require periods of abstinence, and acknowledgement that problematic substance use and addiction is a long-term challenge for many people. And in reading the evaluation, it was quite interesting actually to see the length of time in which some people had spent in the program. And again, there are perhaps positive and negative ramifications from long-term engagement in such a program, because of course, if one were to slip up, then they risk criminalization. But the abstinence model is one that certainly ought to be considered and ought to be addressed. Now, I think what I want to really have us think about and leave folks with is, in considering the drug treatment court model, I want us to consider drug treatment courts in the context of the drastic shifts in drug policy that we are seeing and that we will undoubtedly continue to see. So I started off my talk talking about these shifts, certainly in cannabis and in psychedelics, and then conversations about harder drugs. I didn't mention the fact that, of course, south of the border as well, Oregon as well has decriminalized drugs, and other jurisdictions are looking at doing the same too. Many folks would look to Portugal as one of the key models, but we are seeing greater and greater uptake. So in a world in which our drug policy is evolving, and in some places somewhat rapidly, what does this mean for drug treatment courts? What does it mean to have drug treatment courts in an environment where drugs are legal or decriminalized, right? What does this mean for an abstinence-based approach? How can we make our approach to treating people with substance use disorder more inclusive, while at the same time, again, avoiding the pitfalls of net widening that I mentioned before? And I think importantly, we should be considering, of course, not only what drug treatment courts can learn from other harm reduction and substance use and misuse programming, but also what can drug treatment courts teach our broader health and justice system. What can be exported outside of the CJS? Drug treatment courts take a different approach to considering drug use and drug users than a traditional court would, right? What can the rest of the justice system learn from that? So these are not questions that I necessarily have answers to, but I think these are questions that we should continue to ask ourselves, not only throughout the rest of today, but as we move forward with our work. And on that note, I know I started a little earlier, but I'm finishing earlier than planned, but I want to say thank you very much, and I welcome any questions.
Thank you, Akwasi. Thank you for sharing your insights on the consequences of policies on drugs and the shift in drug policy landscape, including the discriminatory reasons and racism that led to our current drug laws. Your work in this field is so important to us, and we can take away many key points from your talk today for consideration in the work we do, whether it be research, policy, or direct services to clients. We do have a dedicated Q&A session that I would invite you to join us, Akwasi, and participants of the forum can post their questions, and we will be going to that after a quick break. We are going to take a 5-minute break just to stretch our legs, and we'll be back. Now it's 10:15. As you can see, we are well ahead, which is great. We'll have more time for questions and answers, and having a much more time for a conversation in the discussion period. And so it's 10:15. How about we are back around 10:20 to 10:26? Please stay signed on and we'll be back at 10:20. Thank you. All right. Welcome back, everyone. I hope you got a minute to stretch your legs. At this point, I would like to introduce the next agenda item, which is the panel. And first of all, it is my pleasure to introduce you to the moderator for the panel, and who is Sean Sherry. Sean is the Interim Director of Policy at CMHA. And the first speaker in the panel is Stacy Shanks, who is a registered psychotherapist and works as a counselor in therapeutic justice program at Lanark, Leeds, and Grenville Addictions and Mental Health. Welcome to the panel, Stacy. We're very much looking forward to hearing your presentation. Stacy works with clients from Drug Treatment Court, Mental Health Court Clinic, and Custody Release Clinic. It is also my pleasure to introduce Robin Cuff, who will be speaking after Stacy. Robin Cuff is a registered psychotherapist and the manager of the Toronto Drug Treatment Code program at the Center of Addiction and Mental Health. Robin is the faculty member of the William Glaser Institute for Choice Theory, Reality Therapy, and Lead Management. She has practiced in participated in developing best practices for women's addiction treatment, withdrawal management, and trauma, among many other notable accomplishments. Thank you to all three of you, and I will pass it over to Sean.
Excellent. And I just wanted to remind folks that you can put either in the Q&A box or the chat box any questions you might have for any of the presenters today. But we'll hand it over to I believe Stacy is starting first, and then we'll turn to Robin, and then I'll take some time after that to answer questions about this panel or any of the presenters we've had this morning. And just a reminder that we also are recording today's session, so we'll share that as well as the slides where we have slides. So I will turn it over to Stacy to talk about her DTC. Thank you.
Thank you very much. I'm just going to share my presentation. Looks different than before, so I'm hoping that you're just able to see my main slide, but sorry, Stacy, it looks like you're in the presenter view, so if you go to the display settings, which is not where it was before, would it be down here? On our screen, it's at the top. Which is where it was on mine earlier, and I don't see that anymore. Oh, there we go. Okay, is that better? Yes. Okay, sorry. So as Sudha had mentioned, I am from Lanark, Leeds, Grenville Addictions and Mental Health. So I'm the counselor with our drug treatment court, along with our other therapeutic justice programs, which includes mental health court and custody release. So I wanted to give some context first in terms of the area that we serve, because it's quite different than the urban centers. So we have a very large geographic area that's comprised of 2 separate counties, and we are situated between Kingston, Montreal, and Ottawa. Over 60% of our population is in a rural setting, which can often mean unreliable internet or no access at all, transportation barriers, and lack of resources. So in our area, we do not have a withdrawal management center. People need to travel to Ottawa or Kingston in order to access those services. Luckily, this summer, our Brockville General Hospital did introduce a 4-week inpatient concurrent disorder stabilization unit, which was a welcome and much needed addition to our community. In terms of the development of our program, in 2016, Justice Peter Wright, who was involved with the Ottawa Drug Treatment Court program, had set the initiative to develop a program for our area, which was supported by our justice partners and my mental health agency. Unfortunately, as was mentioned earlier, there was no funding available for the program when it was started. So treatment staff were required to add group facilitation, case management, and court support duties on top of their regular roles. The following year, the agency was able to obtain funding to develop its mental health court program, and the decision was made to have one case manager and one counselor to support both of those programs. And in 2019, the Attorney General did review our treatment program from as it was developed, and it was accredited through that process. The flow through of the program as it stands now is we receive an application from the Defense Counsel in consultation with the applicant. And at the time of referral, over 50% of the applicants are actually in custody at that time. The Crown is responsible for initially reviewing the application, and they must approve before it's moved on to the treatment team. Once that is completed, we meet with the clients for a initial assessment. And then if they're accepted into the program, they begin in our intensive drug outpatient treatment program, which includes groups, individual sessions, vocational supports, and psychiatric follow-up. When they complete the program, the treatment team would assist them to transition to whatever community services may be needed. Looking at our admission criteria, the applicant must have a self-identified substance use issue, and the charges must be drug inspired. So typically the applicants that are considered for the program are facing a custodial sentence of 6 to 9 months. Although since COVID, we've noticed that the Crowns have been more flexible, allowing for those with proposed longer sentences to be considered for the program. However, they cannot, the charges cannot include violence or for-profit drug dealing. The most important criteria is that applicants would be willing to participate in the program and abide by the court conditions. It is a voluntary program and an alternate to custody. And the legalization of cannabis actually did not impact on how cannabis was viewed in our abstinence-based program. The small shift that we have had is a participant who was on, who using medically prescribed cannabis advocated for himself to continue with his prescription, which led to the treatment team and the justice partners to review this request. And it resulted in the policies being amended to allow for medically prescribed cannabis. However, non-medical cannabis is treated the same as an illegal substance or alcohol within the program. So there's no consumption unless it's prescribed. The way that our court works is we try to have the same justice partners present. So the judge, Crown, and Duty Counsel are often there. Probation is sitting at our table as well. This is to help build rapport and trust. It's run week to week, so we do build rapport with them over the duration of the program. Participants are actually required to plead guilty to their charges prior to entering the program, and they are entering into a specific release conditions that include maintaining abstinence, reporting substance use to treatment and the court, an initial period of house arrest followed by a curfew. It's based on a rewards and sanctions model where rewards are given for participation and meeting program expectations. And it includes things like a coffee card, praise and encouragement from the court, and increasing privileges while they're in the program. And sanctions are used to encourage compliance with the program expectations, and it does try to keep in mind the therapeutic rationale of the sanctions. So those would be things like community service hours, additional writing or homework exercises, but it can include short bail revocations. And participants are in the program for 9 to 12 months, depending on participation and their abstinence. So initially, when we began this program, there was a 30-day assessment period, and this gives the participants an opportunity to try the program. And if at the end of that time they don't want to proceed, they're able to strike their guilty plea and return to the regular justice system. We did notice this wasn't a long enough time to assess all the clients, especially those who were daily cannabis users prior to entering the program. So we did extend the assessment phase to 45 days, and we do have some flexibility because we do use urine screens to monitor abstinence within the program. So often for those who were daily cannabis users prior to the program, it would take longer than the 30 days for the urine screens to read negative for THC. And we've just actually implemented some new changes to our treatment program. After doing a program evaluation, we redesigned the treatment component and implemented this in 2021 based on the needs that were identified, not just in drug treatment court, but also in mental health court and with our custody release clients. This new treatment program is open to all justice clients. The model is actually based on a phased approach, which is different than we previously had. And it starts with the most intensity of virtual groups, Monday to Friday, along with weekly individual sessions, vocational planning, and psychiatric consultation. We take much more active approach in terms of looking at school work and volunteering as an engagement tool for the participants in our program. And as they move through the phases, they have reduced group time and increased opportunity for work and employment or schooling. And in the final phase, we really look at an individualized treatment plan and work towards what their goals are in terms of moving forward. Really, the carrot with the program is that a custodial sentence is off the table for successful participants. So initially, we would have seen a lot of suspended sentences followed by a period of probation. But more recently, our crowns have been more flexible, and we've seen outcomes such as withdrawing the charges, stays, and conditional discharges, which I see as an improvement in terms of the outcome. And I just wanted to give a sense about who we're seeing in our program. It is a relatively small program given our area, but in terms of on the applications, participants are asked to identify which substances they consider to be problematic. And as you can see, the majority indicate polysubstance use, and specifically in that group, 16% would identify cannabis use. And 3% of our total applicants reported cannabis use as their main concern. Typically, what we are seeing is a lot of crystal meth use and other stimulants, as this is what's highly available within our communities. And then over the last year, the most common charges have been trafficking charges and simple possession charges, but it's noted that almost all of the participants are facing multiple charges at the time of their application. In terms of our program stats, so less than half of those who apply for the program actually are accepted. We see the Crown declining applications due to violence in the offenses or violence in their history. Treatment has typically declined based on lack of suitable housing. So given the intensity of the program and the requirements of daily contact, without stable housing, it would be very difficult to participate. And we don't have any shelters in our communities except for youth. So that wouldn't necessarily be an option. Applicants themselves would often withdraw their application when they didn't have sufficient information about the program prior to applying. I just would also like to point out that we've had over the program 6 years, 98 applications. So this is in stark contrast to the over 300 participants we've had in our mental health court, which is actually 2 years younger than our drug treatment court. So it's very interesting to us as the treatment providers for both programs, because we know that over 90% of those who are in our mental health court program have been diagnosed with a substance use disorder as well, which is part of the reason why we advocated for the day treatment program to be open to that group of clients as well. In terms of outcome measures, so we do have that assessment phase. So about 28% did not continue after their assessment phase. And that could be due to dishonesty with the treatment team in the court or continued criminal activity. And after committing, that's a quarter of those participants did not complete as well. So in total, we have 42% that have completed the program. And so these are just some issues that have arisen within our program that have been mentioned before. I mean, we obviously are seeing quite a difference in our referral rates for our mental health court and our drug treatment court programs. Access and transportation are definitely issues within our community, although our justice partners have done a great job of trying to have donations come to our program to help alleviate some of those costs. Suitable housing and not enough staff. So those would be some of the things that we need to address. And we're looking forward to a new manager with some great ideas and strategic planning to help us to further develop our program. And that's it. Thank you very much for having me.
Thank you very much, Stacey. That was great to hear about the experience in your community. And now I will turn it over to Robin to talk about the Toronto DTC.
Hello, sorry about that. In my effort to bring up my presentation, I actually made it go away. So perhaps instead of bringing that all back, I'll just talk. There were only a couple of slides. Thank you very much, Stacey. I'm going to take a little bit of a different approach and talk more specifically about cannabis in the Toronto Drug Treatment Court program. I wanted to start by saying that all drug treatment courts operate in a specific context. So for us, it's the context of our legal system, of the drug culture in our community, the context of our community and crime itself, and the organizational culture in which we exist. For instance, the Drug Treatment Court in Toronto exists within CAMH. I also wanted to say that for our program, harm reduction, trauma-informed, and brain injury-informed principles are front and center of a lot of the decisions and policies and practices that we adhere to. We do not necessarily think of abstinence as gold standard. While people are asked about their drug use, never punish, we never sanction for drug use. And we think of addiction, substance use, problematic substance use as a symptom. And so for us, we have alternative successful completion standards, but for us, the gold standard is around connection, stability, social determinants of health and quality of life. So we've been on a journey. The Toronto Drug Treatment Court program started in 1998, so we've had longer time to change and evaluate and reevaluate where we are. So for cannabis specifically, it used to be that we screened for cannabis regularly. Cannabis needed to be reported to the treatment and court teams. Cannabis was treated like all other substances, and cannabis use was a barrier to graduation. Now, we do not need to screen for cannabis. It's not required. We do not require our clients to report to treatment or court their cannabis use. And it is not treated like other substances by the court. Cannabis and alcohol are a treatment matter and not a court matter. It is addressed if it is preventing clients from meeting requirements. While cannabis use was a barrier to graduation, cannabis is not a barrier to full graduation at this point. So how did we get here? Because that is a big change, and it's certainly not where a lot of drug treatment courts are across the province or across Canada. So maybe we'll start with cannabis for medical use. When that policy began and doctors were allowed to prescribe cannabis for medical use, we pretty well immediately decided that that would be allowed in our program. We take a stance in our program that medication is a right. So we do not disallow any types of medications in our program that are prescribed by physicians. So it doesn't matter whether it's opiate substitution, Cadian on top of methadone, benzodiazepines, or medical cannabis. So that was kind of the first step that we took. We also looked at the increased use and severity of other types of substances. So around this time, we're starting to get into more opioid use, more crystal meth use, fentanyl starting to come on the scene more frequent, and recognizing that those were the things that we were focused on. We had a lot of client advocacy. Stacy mentioned how they had a client advocate for medical use of cannabis. We had a lot of client advocacy for non-medical use of cannabis, with a lot of great and interesting stories around that. People who had, stopped using fentanyl, but they were still using cannabis. And people wanting to be able to be successful in our program, but still use cannabis, recognizing that their quality of life has gone up, their functionality has gone up, their connection in the community had gone up, their ability to work had increased. So we had some fairly strong client advocacy of people who wanted to be able to graduate and still be using cannabis. So we started off with what we called substantial compliance. So substantial compliance was not full graduation, but the impact of it was exactly the same as full graduation. People could be using cannabis, they could complete our program successfully, and the consequences at the end. So graduation in drug treatment court is like a sentencing, but if you've completed the program, you don't go to jail. So we started with a substantial compliance category of graduation. Then we continued to look at the evidence-based material that was out there and the relative harms of cannabis as opposed to others. For instance, the harm of cannabis is less than the harm of alcohol or tobacco. We are not saying that it is not harmful at all. And we are also not discounting anyone's experience for whom cannabis is a very serious issue and has other serious implications. It's just not a guarantee that if you use cannabis, that all of these other serious implications will follow. And then there became the move towards legalization. I did mention that we are part of CAMH, our treatment program is part of CAMH, and CAMH did write a policy and position paper supporting the legalization of cannabis. I felt was a pretty balanced paper where it does talk about harms, but again, relative harms, and supported the legalization. And the reason it supported legalization partially is because when substances like cannabis are criminalized, the relative harms can be greater than the cannabis use itself. And legalization and regulation are important components of this type of movement. And then we did move to legalization. So then our thought and discussion process was, are legal substances really a matter for court? A court that is dealing with illegal activity. So we know that there may be illegal activity connected to substance use, but we made a decision not to address the legal substances in our court. So that included alcohol and cannabis. Of course, any medications that I've already mentioned, unless the medications are not being used as prescribed. So we also re-examined the substances that Drug Treatment Court was formed to address. And if you look back at the original documentation from the Federal Department of Justice, it was basically two categories: substances with some other outliers that don't often happen in our program, but mostly it was stimulants and opioids. And we decided that that was important for us to focus on. And those were the types of substances that were most likely connected to the types of crimes that our clients were committing. So we also listened a lot to clients and our clinic, and we paid attention to our clinical observations and progress. And many clients were reporting that while they were not ready for abstinence from all substances, that the cannabis use was helping them. So as they were using cannabis, but some of the other substance use or the more dangerous using practices were going down, and they were able to, in some people's opinion, manage their anxiety better, manage their other concerns more. We also base our program on harm reduction principles, and we recognize that criminalizing cannabis does not really help anyone, and it does not really stop people from using cannabis. And we felt that if we kept cannabis in the forefront of what people are reporting and how we are dealing with people in treatment, we felt that it was actually playing into criminalization of cannabis. In saying that, treatment does not turn itself away from any cannabis or alcohol issues. They are dealt with in treatment, dealt with as clients need, as clients present, and as clients are demonstrating that those substances are impacting their ability to function, participate, and their recovery journey. We also looked at the relative harms and safety issues to society and how frequent or how pervasive harms to society are as a direct result of cannabis use. And my final point would be that we have been focusing primarily on trauma-informed practices. And for us, that is being client-centered. It is recognizing that abrupt abstinence can actually be harmful to people, and a process is more helpful to people. Also, with harm reduction principles, we know that forced abstinence can also, when people like graduate or are released from forced abstinence situations, they're more likely to overdose. So those types of principles came into play, being what we felt was more client-centered, listening to clients, listening to their stories, joining them on their journeys, and recognizing that the harms and that came with cannabis use, while there was nobody that didn't have any harms, the harms were minimal compared to the harms associated with not just other substances, but the harms associated with racial profiling, criminalization, homelessness, poverty, and those types of. So we chose to focus on the population that we were serving and the severity of the drug use and the other concerns that they were bringing forward. That being said, the other thing that probably is important to note that I should have noted at the beginning is drug treatment courts were initially set up for people who were at high risk, high needs. The high risk meaning high risk of recidivism, and those who have high needs that are presented because of some of the social determinants of health and other criminal behavior factors that exist under the risk need responsivity model. So in Toronto, in the past, I would say 5-6 years, and probably before that, I think we've had one client in that whole time that has not been in the category of high risk, high needs. So we also feel that our response around cannabis is also in keeping with appropriate responses to the type of population we serve. Again, focusing on harm reduction principles, trauma-informed principles, and something that I haven't really addressed, but have mentioned, brain injury informed principles. Thank you very much. I look forward to any questions you have. And I know that Stacy talked about her program. I'd be happy to answer questions about that. Thanks.
Thank you very much, Stacy and Rob. And that was great to hear the two different distinct experiences with DTCs in Ontario. I'll ask folks to put any Q&As in the Q&A section. If you have more of a comment, put it in the chat. There is a question about this, repeated questions about the slides. Tasha, we would typically put them up on the HSJCC website with the recording afterwards, correct?
Yes, yeah, we will.
Perfect. So we'll send out a notification about that. We'll also be sending out an evaluation afterwards. So I will start. There's a few questions in the chat, but I'll start with the ones in the Q&A and then go back to the ones in the chat. There's a couple of questions that I'll direct to our advisory committee. First one on involvement from family caregivers, as well as one on Indigenous representation. So I will hand it over to members of our committee to be able to respond to those ones. Oh, okay, maybe I will try and respond to them. In terms of the caregiver one, we had focused very much on the experiences of individuals in DTCs. So I think that's a future consideration that we would make for sure, that we think would make a lot of sense to move forward on. But at the time, we very much wanted to have the perspectives of those that were involved in DTCs. And as part of our advisory, we had two individuals, so Trevor and Nicoletta, representing both the experience of a person with lived experience in the justice system and with mental health, as well as the experience of a graduate of a DTC. So they helped inform that. In terms of Indigenous communities, we had done some outreach in the early days, and both in terms of capacity and what was going on with COVID when we started the sampling, the partners that we had just didn't have the capacity to be involved. We know that, as Akwasi as well pointed out, that the both Black and Indigenous communities are well overrepresented, both in the legal system as well as criminalization of drug charges. So it was something we looked for, and we would love to do further work to engage around those. But given what was happening with the pandemic and the experiences we had on sample size and partners, it was one of the challenges that we weren't able to overcome. I'll move on to, there was a question from Sydney on, and this is maybe one that our DTC folks could answer. What mental health supports were provided to effectively ensure these co-occurring illnesses were treated effectively?
Stacy, do you want to start or?
Sure. Yeah, sure. So we do have a psychiatrist that works with our treatment team. We're very lucky. Initially, he was only funded to work with our mental health court clients, but through convincing him and some additional funds, we were able to have him provide assessment and ongoing treatment for our clients during that. Most of the clients that are seen in drug treatment court also have diagnosed mental illness, and so they're able to access treatment planning, medication, and ongoing psychiatric follow-up through that. Also, given that I support both programs, I would more consider myself to be someone who supports concurrent disorders rather than an addiction and a mental health separately. So I take that approach with my clients and looking at a more holistic type of what are your needs and how can we best serve them.
I would agree. Our program is intentionally concurrent disorders focused, with our staff all being trained in concurrent disorders, and we have an assigned psychiatrist available.
Sorry,
Sean.
You're muted, Sean.
Thank you. Thank you both for that response. There's another question for both of you around the rates of relapse in the harm reductions versus the abstinence-based court. So do you see any differences in I'd say both your abstinence and your graduation rates as well?
Well, we have a progressive system. So if somebody has a lapse, they're not removed from the program. They're able to work with the treatment team in addressing what areas of needs and trying to work on a relapse prevention plan. So we do have at the end of the program an expectation of a period of abstinence. But I wouldn't say that there has been a difference. Interestingly, I didn't really get a chance to articulate, but in our day treatment program, the approach is non-problematic use of legal substances, so alcohol and cannabis, and no illegal substances. So it's a bit of a, we're sort of shifting ourselves there, but our DTC is still having that abstinence base. But so we do more look at it as an opportunity for support and intervention rather than a reason to remove from the program.
So I would say that since our program is primarily harm reduction based, we are not really looking at relapse rates. We are looking at reduced use and safer use. We provide safer use supplies, for instance, connect people with safe injection sites. So what I would say is that overall, our clients' use has become safer. It has reduced, and we have a tremendous increase in people who are utilizing opiate substitution. And interestingly with that, we have a couple of housing programs as well. We have just, in the past year, we've just employed a part-time nurse, and that nurse is being able to take Sublocade out to the community, to clients in their homes. So certainly there are some people who achieve abstinence and full graduation with abstinence. I think I did mention that full graduation is not our gold standard, and we are looking at ways to measure success that doesn't necessarily include or doesn't necessarily prioritize abstinence, and prioritizes quality of life, functionality, and connection, and housing and stability. I know that wasn't a really clear answer, but it kind of gives the context of where we are. We see substance use as a symptom.
Thank you. That was very helpful. And then we have a question from Sydney, who said trauma and socioeconomic instability are addressed. What about those with hereditary mental health diagnoses? And are you acknowledging extremely limited access to treatment? So I'll turn that one over to Robin and Stacy as well, and if Kwasi has any comments on that as well. Robin,
Would
you
you
want to go
mind,
first?
would you mind repeating the question? I'm sorry.
Yeah, it's a bit of a packed, multi-pronged one. So trauma and socioeconomic economic instability are addressed, but what about those with hereditary mental health diagnoses? And then it's sort of a second question: are you acknowledging extremely limited access to treatment as well in this?
Okay. So for us, I would say that how we deal with anything that's hereditary or any other mental health issues is, while we have a core program, we individualize. And that is our response to pretty well anyone and any challenges that they bring. For instance, we have a number of clients that have developmental concerns. So we individualize for them, and even the requirements of graduation, it depends on what they're able to do. What their we include doctors, families, and those types of supports as well. Yes, limited treatment resources. You know, even in a city like Toronto, there are limited treatment resources. I am situated in CAMH, you know, there's long wait lists. I would say that Stacy might have more to say about this because their situation is more limited. What I find is a challenge is that as soon as people discover that our clients have a criminal history, that's an added stigma, which makes access to treatment, housing, and other things more difficult for our clients. And our clients come to us because they regularly break the law. So following rules is not something that comes naturally to people, and they often get discharged from programs easily. So we find that we are, you know, in addition to providing treatment, we provide a lot of advocacy and case management, and we find that we are constantly advocating within the various systems for access to treatment and maintenance of treatment.
I'll just echo that. Yes, I mean, I've worked in Toronto, I've worked in Ottawa, and now I work in a very rural setting. It is very different. We are the treatment. We don't have resources that we can go out to. It is done in-house. We're lucky enough to have some vocational supports that we partner with, but otherwise, people are traveling outside of our area. They're needing to go to Ottawa, to Kingston, to access that. So then we face transportation issues. The wait lists in those cities. So the feedback from our clients has actually been, as sad as it is, that they are thankful that they had the opportunity to participate in our program, because in order to get a psychiatrist in a timely manner, you almost need to be before the courts, because we have immediate access. You know, whereas if they go through our community psychiatry, they're waiting 6 to 8 months. So we can do all of the what we can within our program, and then we need to look outside of our community, which is really difficult for our clients. And we do our best to advocate within those urban centers to try and support our clients in whatever way we need, as well as I second Robin's notion around individualized planning, is that we are, as much as we're working within the abstinence framework in terms of where clients want to go with their life, we really work towards what their individualized plan is, so that they're able to move forward from the program with something that is of their own creation.
Thank you both. Kwasi, anything you want to add to that conversation?
Nothing further from me. Thank you. Thank you, Sean.
Okay. Thank you. And we have a question from Jean-Marc, and I think it was originally for Stacy, but I think I'll ask it of everyone. Have we seen a decrease in people being charged for drug-related offenses in your area specifically, and overall in the province? So I'll turn that over to you, Stacy.
Sure. I would say, I mean, we had a pause during COVID where everything sort of shut down with the courts, but I would say, in fact, we are actually seeing more within our area, at least within the last 6 months. We are in a high traffic zone, being along the 401 corridor between major cities. So we do seem to be a stopping off point, and we have organized crime that uses our laneways. And so actually, I would say that we've actually seen an increase, and we're seeing much more of the possession for purpose of trafficking than we are of the simple possession. So, which I think before was often screened out by our crowns, but is now being looked at in terms of where, they are in the chain of dealing, that the trafficking doesn't automatically mean that they should be excluded from our program.
Yeah, that's very interesting observation there, Stacey. One of the things that we've seen, and I think you noted, the pandemic is a shift in charging practices. Might have been 2 years ago now, the Public Prosecution Service did receive a direction or send a direction out to crowns not to proceed with simple possession charges. And we did see a huge decrease in Ontario following that directive. Now, based on what you've said, I wonder the extent to which some of those possession for the purpose, that some of the reduction in the possession were previous possession for the purpose of trafficking that were dealt with as possession that are now proceeding as possession for the purpose of trafficking, as they would have had they not been kind of graded down. So the possessions, we saw a drastic decrease, but now I want to go take a look at the numbers and see what those possession for the purpose have done, because there might have been some shifting there.
I would add that it's also very contextual. If you're in a city like Toronto, all of the decriminalization talk, even though I have been a strong supporter of it, really doesn't impact our DTC very much. Simple possession is not something that most of our clients, they may get charged with it, because typically when somebody's arrested, they get charged with tons of things. But I do not recall the last time somebody came into our program based on a simple possession charge alone.
Excellent, thank you for that. And there's a question specifically for you, Robin, from Sydney. How are caregivers being engaged at CAMH to ensure success for their child in the program? So I guess addressing probably the ages of who's involved in your program would be helpful as well, knowing it's not adolescent specific yet.
Yeah, so we only serve adults in this program. That being said, part of accreditation standards for our organization is the involvement of family. And that being said, most of the clients that we serve in drug treatment court no longer have family involved or family that they would consider to be supportive or helpful. So of course, the first thing is, what is client choice around family involvement? We do have a family addiction program at our organization so that families can get assistance that way. In saying that, when client choice, and we always address it in our assessments and further on in our program, who do you identify as family? And we do rely on clients to talk about their chosen family, who they identify as family. Sometimes it's parents and sometimes it's not. We ask who is involved, who you would like involved. Can we get collateral information? Can we have family conferences? Those types of things are addressed and left, of course, to client choice. So we make attempts, no matter how old. I see that Sydney says age has no barrier, which is true. No matter how old a client is, we do make that effort with our clients. And quite frankly, there are things that may seem unusual for us. We had a client living in a car with his family for a long time, and we went to the car and we served the client there. They did not want to leave it. So it really doesn't matter to us what context it is in. You know, we've helped family members find assistance, find housing themselves. But for us, getting family collateral under the personal health information legislation does require client consent if the client is an adult.
Thank you. That's very helpful, Robin. Stacey, do you have any caregiver or family involvement in your DTC?
Yes, we have a family support worker within our agency, so that's often a point of referral for family members. And given that a large number of our clients actually live with family members during their involvement in drug treatment court, we often will have some very open discussions about the expectations, because sometimes, especially given the number that we have coming out of custody and into, say, a family returning to live with their parents or a family home of some kind, it is important that they understand what some of the rules and expectations are, and also that the family member is not responsible for ensuring the person follows the rules, because sometimes that's been problematic in the past where families feel that they need to enforce the rules. And really that's not their role in this, and we try to involve them in the treatment care plan. But of course there does need to be consent for specific information sharing, as Robin had mentioned. But in terms of information about the program, supports within the community, we do try to ensure that there's access right from the beginning of the program.
Excellent, thank you both. We have a comment from Shane. This is probably for all, but I think Kwasi, if you could start off, that would be great. So unfortunately, once you legalize cannabis, you open the door for organized crime. I can't speak for the entire province, but the legalized aspects has now provided easier access to youth. Is it a coincidence that cannabis use has risen in the north since it has been legalized? So a multi-pronged question, but I'll turn it over.
Can you repeat that again, please?
So they start off asking about legalizing cannabis and opening the door to organized crime, and then is legalized cannabis also? They're commenting saying it's providing easier access to youth, and then that there's been increased use in the north since legalization.
So I think what legalization has done has provided different avenues for entry or participation for organized crime. So organized crime has undoubtedly always had or played a role in the Canadian cannabis industry. Prior to legalization, a significant portion of the especially the larger scale trade in cannabis in this country was undertaken by organized criminal organizations. Legalization, of course, even the medical models certainly provided different ways for them to get in. I think undoubtedly, though, the legal aspect of the cannabis market and anyone who moved from illegal to legal has taken profits away from organized crime. So I don't want to say that organized crime is not involved, because they most certainly still are. But as we see greater uptake of legal cannabis and less uptake of illegal cannabis, then the organized crime element will, organized crime will have a smaller piece of that pie. With respect to the change in rates of use, again, the initial survey data that I'd seen from Statistics Canada indicated a slight uptick following a trend that existed prior to legalization, but may have come about in part because of the normalization of cannabis prompted by the recognition that it was going to be legalized. So essentially, the government saying it was going to legalize may have already sent a signal to people that, there was something different. There was less stigma around the plant than there had been before. But again, I haven't seen information or data on regional variation. I will say, I think we could expect with normalization some shift in use. Now, again, one of the government's main tasks or aims with legalization was to protect young people. And so we will see, and of course, this is me passing the buck on to someone else, the review of the Cannabis Act, I hope, will provide us with much more robust data to see what has happened. But undoubtedly, and as I mentioned, I'm in support of the legalization of all drugs, and I do recognize that legalization will bring with it some shifts in consumption, and these are things that we'll need to pay close attention to, in particular to reduce the negative health, personal, and social impacts of any problematic use.
Thank you. That's very helpful. And just I'll note as well that the Mental Health Commission, who has funded the research project in particular, and the findings that we'll share from today, they're using the work that they have funded to help inform the review of the Cannabis Act. So some of this work that we're doing will be part of a report that they'll share for the benefit of informing that review. I have a question here that's directed at Robin, but I'll ask it both of Robin and Stacey. So Sydney says, trauma-informed care is great, thank you. Are you also addressing those that have hereditary mental health diagnoses and providing CBT or DBT, so behavioral therapy skill training, as part of your programs?
Okay, sorry, Stacey and I keep looking at each other, just who's going to go first. So yes, we are providing CBT and DBT informed interventions in our program, and sometimes we are also referring to other programs, for instance, seeking safety and types of interventions.
And for our agency, it would be part of the more individualized treatment plan as they're progressing through. We have an internal group that is called STEPS. Some people have referred to it as like DBT Light, because the wait list for DBT in our area is quite lengthy. So that might be part of the longer term treatment plan, but they can access the STEPS groups while they're in the program. And a lot of our groups are actually based on REBT, so rational emotive behavior therapy, and we take a lot of the different tools and skills found in Smart Recovery. So we often use that as a way of also linking to resources within the community from mutual support groups that they can participate in the program and beyond if they choose.
Helpful. And the next question is one for Megan in particular. I know that it was you had talked about it in the chat, but a question about the sample survey size. And I know we had our original target of 70. What was the sample size, both with the participants as well as the folks working in the courts?
Yeah, so as mentioned, we did have that original target of 70 service providers and 70 clients. So through the client survey specifically, we had 29 clients at the beginning. And then that kind of tapered off to 25 by the second one. And then ultimately during the third and fourth survey, we had 22 clients. So those were 22 of the 29 we originally started with. And then we did do like with the service provider engagements, we had 15 through the surveys, and then we had 5 through interviews. But with interviews, we still are in process of doing that with clients. So we have 2 so far, but we are still interested in speaking with any client participants who want to share their experiences. And I did also want to take this opportunity, if I may, to just kind of go back to an earlier question that was posed. Sydney, you said, why were the caregivers and those with lived experience not a part of the planning team and co-designing the research for best results? I know Sean touched on the caregiver bit, and did discuss, that Trevor and Nicoletta were a part of the team. But I just wanted to clarify, and I should have been more clear in my presentation, I apologize. But Nicoletta and Trevor have been with us since the start of the research, and they have been a part of the planning and the co-designing of all the tools, the research ethics application. They've been advising us on what to do. So they have truly been a part of our team. And so when I speak about, the team did this, I am really speaking to Nicoletta and Trevor as well.
Thanks, Megan. And maybe I'll get Akwasi to speak to the landscape that occurred during COVID for all of the research that was going on, because Akwasi was one of our advisors, and we had that 70 target planned pre-pandemic. Many of the courts had stopped or froze during that time, but you sort of spoke to what was happening in the landscape at the time as well.
Yeah, absolutely. Of course, as service provision, ceased or moved online, that shifted how researchers could track, participants in projects. I will say, taking a step back, I think my almost entire research landscape changed during the pandemic, the way in which, of course, I was collaborating with my peers. But even thinking about, I mentioned some of the Statistics Canada data around drug arrests that I'd been looking at. And it took a lot longer to get information from Statistics Canada than it might have otherwise. And this is, a federal agency pulling data from its usual data sources. For organizations and projects such as this. Data collection became very difficult. There were, of course, a number of challenges and concerns that people were facing. Work that would have been done observationally or in face-to-face certainly was no longer taking place or was paused. And so we at the university were getting lots of extensions on our projects and having to change the way in which our research was being undertaken. And I think that was reflected, it came as no surprise to me when Megan and Reza and the rest of the team and I connected that we needed to pivot, and there had been some challenges. So undoubtedly, I think what this research project experienced was kind of mirrored across a variety of different types of research, and certainly not unique to this space, which is one that can be a challenge as it is, especially when you're dealing with populations that are facing issues, whether that be related to criminalization, related to mental health, and certainly that are stigmatized.
Thank you. And I have a question from Angie, and I think it's for Robin, Stacey, and Akwasi, but it's, as we discussed, as Akwasi was pointing out, the move from decriminalization and legalization and safe supply program. So it was mentioned that DTCs aren't for substances that have been decriminalized or regulated. So what does that mean for DTCs when we decriminalize nationally and regulate all substances? As we add to the list of potential substances, what would that mean to DTCs? So I'll turn it over to Robin.
Okay, so when DTCs were set up, marijuana was not legal, but they were set up to address the issues that were more related to people who were using stimulants and opioids. So I don't necessarily see that it would have the biggest impact except on possession, because mostly we're not seeing people who are coming to us because of possession or the type of substance they use. We're seeing them come to us because of the crimes that are associated with it. Now, if the substances are legalized, I think what I would say, I'll be bold enough to say that even though I've been in this business for a long time, probably 12 years, I dream of a day when we don't need drug treatment courts. I would love for us and society to join together to work our way out of what I would consider a stopgap and an intervention that is not necessarily the best, but it's what we have to offer right now.
I think Robin covered that very well. I really honestly don't have anything to add.
I just want to say kudos for, kind of being brave and demonstrating leadership and saying such things, though, I think that's important to recognize. Thank you.
Thank you, everyone. So there's a question here drawing on, I think, the experience that Akwasi presented around us having a very deep history of racialized drug policies. So a question probably more for Robin and Stacey, but how do you as white people negotiate working with clients that are affected by white supremacy in such important ways within a system that is steeped in racism? Do you interrogate your role in the system, and how do you support persons of color in doing this work?
Okay, I think I'm starting. We do interrogate our role in that. Our hiring practices. We do try to hire people who are not white Anglo-Saxon. The majority of our staff are, but we are interrogating our processes. We have just started to look at, just as an example, at our last retreat, I don't know why we call them retreats, but our retreat is a meeting where all the treatment providers and all of the court team meet together and talk about our concerns. At the last one that we had, we talked about how we are going to address some of these issues. So one of the things is that when clients apply for drug treatment court, so the treatment team doesn't get to decide or see the applicants, the Crown's office does. And I don't believe it's on the questionnaire what ethnicity or any of those things are, any of the diversity questions. They are on our questionnaire when we accept people into the treatment program, but that's after they've been accepted into the program legally. So we're looking at two things right now. One is looking at the proportion of people who are non-white that get accepted, how we can gather data to see if people are not being accepted and they are also part of racialized groups that tend to be charged more frequently, charged more severely, not given bail, targeted, all of those things. So we're looking at eligibility criteria. So we have this eligibility criteria that may very well be more suitable to people who are white and don't have some of the targeting and some of the other problems within our justice system. So we're looking at that to see proportionately who's applying, who are we accepting, and on the other end, who leaves early or who gets discharged from the program. So those are just a couple of examples of what we are trying to do within our program to address this. In addition, if people are Indigenous, we offer them Indigenous services. We offer them the services of an elder. If we will substitute portions of our program so that people can connect to religious or cultural services. So if there is a program that is culturally specific, we will substitute one of our groups and encourage them to attend that group instead. I know that none of this is enough, but in answer to your question, those are some of the things we're addressing and looking at.
I would just say for our agency's perspective, I mean, again, I second Robin that it's not enough. There's always work to be done and more to be looked at. With our program evaluation, we are doing the same in the sense of trying to see what more we can do to assist applicants to participate in the programs, to make it more accessible, to make it more encompassing of what applicants' needs are. We live in a probably more homogenous environment than something like Toronto. So there isn't as much availability for those additional resources, like specific, culturally specific. But I think that's when we work on an individual level to ask participants, what do they need? What's going to be helpful? What can we connect you to have an understanding from their perspective as to how to best support them. But it's always incumbent to continue to learn and to listen about what we need to do as service providers to ensure that we're addressing needs as they present to us.
I will add that
the system too.
I will add that we in Toronto, we are also bringing a lot of immigration supports. Often when our clients, because of some of the laws that exist, when our clients graduate, it means they've now been sentenced, and that sometimes triggers a deportation order. So we are working with immigration workers and lawyers as well.
Excellent. Kwasi, any thoughts on this, knowing that you sort of shared some of the history of of racialized drug policy, as well as the fact that DTCs seem to be benefiting white persons more so than racialized individuals. So any other thoughts on how to best address those?
Yeah, well, I think it's, incumbent upon, and again, appreciate Robin's comments, incumbent upon people working in this space to understand like how it is that, we're in the situation we're in now with respect to these huge racial disparities. They have not emerged from nowhere, and having a sense of that history and its current day manifestations. And I think it's important, again, to recognize how, as a criminologist, I see how drug law enforcement and the connection between racialized populations and drug use, especially Black and Indigenous people in this country, Black, Indigenous, and Latino people in the United States, for example, like serves to further entrench their marginalization, right? Like drug law enforcement has played a large role in contributing to their marginalization. So again, taking it back, I think it's incumbent upon individuals working in this space to learn about and recognize these disparities and work to ameliorate them as they go about their daily business.
Thank you, everyone. And I'm going to pop over. There were some questions in the chat that I'll get to before we go back to the Q&A. So Alana asked, Akwasi, please revisit how legalization of hard addictive drugs would benefit society other than some regulation and tax revenue. Violent offenses occur when crack and crystal meth are involved, for example.
Yeah, so from my perspective, drug criminalization has done nothing to achieve its stated aims, right? Which are to stem the flow of drugs and stem the use of drugs. So we haven't seen that happen. So again, if you look, I'll give the example of south of the border. Since the war on drugs was declared in the United States in the 1970s, drug use has increased over that period of time. What has come along with that as well is a multi-billion-dollar trade, illegal trade in drugs that benefits organized criminal elements. It benefits, a number of people, but in large part organized crime, which use those profits to fund other criminal endeavors, human trafficking to support prostitution rings, arms smuggling, and a variety of different nefarious activities. So our war on drugs fuels criminal enterprise. Our war on drugs also fuels a very problematic style of policing, right? So the war on drugs and the war on crime quite literally create wars in which you have two opposing sides, a law enforcement side, and the opposite side is often, again, marginalized communities, and they quite literally do battle in the streets. And so beyond that, of course, there's the unregulated, so the illegal supply of drugs is one in which no one knows exactly what they're getting in terms of their products unless they take them to be tested. And so we have huge issues related to the purity and the quality of substances that people are using. And so from my perspective, and this is one I think that it is shared by many and increasingly shared, is that drug prohibition as we know it now creates more harm and creates more problems that it solves. And so it is time for a new approach. And again, that's not to say that legalization and regulation will not be without consequences. Again, I think that it'll destigmatize drugs in a way, and it'll normalize drugs in a way that may lead to people who wouldn't have otherwise using drugs. But again, if we stop thinking about drug use as a criminal justice problem and think about it more from a health and mental health and a social well-being perspective, I mean, we address the root causes of problematic drug use, which are largely born out of trauma, and we leave people who are using drugs in a safe or relatively safe way alone. Because from my perspective, individuals, for most of human history, drugs have been legal, right? Like it's only the last 100 or so years that we've criminalized drug use. And many people use drugs, whether that be cocaine, some heroin, many alcohol, tobacco, and caffeine on a daily or almost daily basis without serious harms to themselves and to others. And again, depending on the nature of drug, there may be more harm, but I think that this is something that we really need to shift our approach to in our criminal justice approach, other than funding our criminal justice system and other than bolstering the careers of politicians who've championed a tough on crime approach, has been of little benefit to our society.
Thank you, that's helpful. There's a couple related comments and a question tied together. So Brian started by sharing his experience saying, I've suffered a lifetime with panic, anxiety, and PTSD. I have a legal prescription for 7 years before it became legal. And all the benzodiazepines they originally gave me were a dismal failure. And I think Brian had shared another story of somebody he knew in the Q&A as well. And then Steve also said, I think the fact that they mentioned non-medical use of cannabis being prohibited is interesting because doctors in Ontario seem to be still resistant considering prescribing cannabis medically. I think it would help for continued research into proposed medical use. And I wonder if these DTCs or their accompanying programs might consider medical consultations for those in these programs to see if perhaps they may qualify for a prescription. If they don't already have one, it might be a way to begin to bridge the way from abstinence with cannabis use. And maybe Stacey, you could speak to your experience that you highlighted with the individual who advocated for themselves who had a prescription. Yeah.
Sure. So he actually had been using medically prescribed cannabis for quite some time for chronic pain issues. And then he was in custody, of course, was not allowed to use that while he was in custody. And when he was accepted into drug treatment court, he actually tried for a while without it, but wasn't able to sleep. His mental health was deteriorating. And he was very organized in his case to the drug treatment court in terms of this is why I need it, this is how it would be helpful, and collaborating or providing supporting documentation from his doctor. And so that was really taken into consideration because I mean we are in the business of trying to help people live well and what that means to them. I haven't found that access hasn't been a barrier, at least in our area, and I think that has been a lot of virtual services that have cropped up. So I haven't noticed that or had participants complain. And to be honest, he's been the only person who has followed through with that in our program. Now our program numbers have been quite low because of COVID and things being shut down. So I wouldn't say that's necessarily a reflection of the landscape, but it hasn't appeared to be a barrier since our program allowed the prescribed cannabis.
Excellent. Robin, have you seen any impacts of the medical cannabis perspective in your program?
I'm not even sure we differentiate anymore because people are allowed to use cannabis. So certainly before we opened it up, we did not, and maybe the question is, do advocate or support people or connect people with doctors who are prescribing? I would say that haven't really gone there, but we certainly have supported people and just accepted it as it is. So I guess no, we have not intentionally reached out to connect people, but we have told our clients that it's perfectly fine and we would not stop them, and it's not something they need to keep hidden. And that was one of the things that we were saying from the beginning. It's not something that you need to hide or be ashamed of.
Yeah. Interesting. And maybe Kwasi, you might be able to comment on this. I know I was on one of the technical briefings from Health Canada when they were shifting some of the policies with the Cannabis Act, and obviously medical cannabis came through a number of court challenges and was in place. That program was in place because of that. And then they described, the recreational cannabis, and then they described the medical cannabis, and they had reclassified it as a distribution system versus a medical program when they did the Cannabis Act. So it's sort of, it almost was like a shifting of responsibility of dealing with medical cannabis. And then they created a third category of products with, cannabis in it that were medically tested, where there was, randomized control trials where you could make health claims, and that the medical cannabis program, you weren't allowed to make health claims. I don't know if you're familiar with some of that history or can speak to some of that shift that Health Canada did.
I'm not familiar enough to be able to speak on it with any kind of authority beyond what you said. No.
Yeah, it seemed like the washing of their hands of the medical cannabis program. They saw it as a distribution program only with the change. Yeah.
What I will say, certainly, what I hear from the medical user side, patient side, is that they feel that they've been now like heavily neglected and left out following legalization, right? So when the first licensed producers came about and were able to produce medicinally, you know, a lot of product kind of coming online, but those licensed producers really had their eyes on the recreational market because it was just going to be so much larger. And so patients have really taken a back seat to medical sales. And in retrospect, that was, you know, a bad idea. One, because, you know, patients need access to that medicine, but had they been smart about it, and especially with people, some people being able to write this off as a medical expense, if they'd had 2 tiers and allowed people to get access and do so, you know, they would have had a more satisfied customer base. Now everyone's just unhappy, or many people seemingly.
Thank you. And then there's a couple questions here from Angie, and we might have to end there. I know we're coming up on our time, but there's a couple of specific questions. So to clarify, is someone with a problem with alcohol alone, are they not eligible for a DTC?
They are within our program. That is, we've had a number of participants who've come, and having impaired charges as well. So with the accreditation process from the Attorney General, their crowns have more, and the court has more ability with the mandatory minimums that I don't think are as much at play anymore, but at the time of accreditation, so that they could remove the custodial sentence for people with multiple impaireds. So don't, if that's their identified substance use issue, then they're able to receive treatment from us.
They're not in our program. We were the first program established in Canada through the Federal Department of Justice, and it was clear who our target population was. And I think maybe part of it is, you know, the numbers of people that would access us. I will say, just interestingly, that most of our clients do not seem to have a serious alcohol issue. It is mostly polysubstance, opioids, and stimulants, and at this point, fentanyl and crystal meth, the most common substances. But no, we do not accept alcohol only, marijuana only, or only alcohol and marijuana, and never have.
Thank you. And there's Angie has a provocative question. Maybe I'll end with this one. Would it make sense to combine DTCs with mental health courts?
I would say for our area, it would actually make sense to have a community treatment court, just given our resourcing and knowing the overlap in the presenting issues. I think we only distinguish who goes where based on what charge they are facing. And I think the courts could do that through whatever conditions they're going to place, or, you know, their projected outcomes. So I think for resourcing in our area, the treatment plan would be, I think, more efficient for us as a team, because we're just kind of dividing our time. And we service all through, like, both the counties for both programs. So I think for our area, it makes sense, maybe not for other areas though.
For me, it's a question that I've gone back and forth on many, many times. I think there would be a benefit, and at the same time, in Toronto, the mental health court and the drug treatment court operate very, very differently. And the drug treatment court has built-in intensive treatment and connection and a treatment center. Their goals seem to be a lot different. I actually think if you're going to have therapeutic courts, then having a joint therapeutic court with shared resources is really a good idea. But then I think we would ultimately end up having streams within that therapeutic court environment. because the goals and the concerns are very different. And I do know that a lot of the times, and I'm not making any judgment or any proclamation on how it is, but a lot of the times a focus in some mental health courts is to have people be medication compliant, and then that that resolves in some people's minds some of the issues. Whereas a drug treatment court, it's a different type of focus. But again, all the courts are different. And so I guess the jury is out on that. But for a center like Toronto, I do believe we'd end up having overlap, but streams as well. And that's not a bad thing.
Excellent. I just want to, I'm going to hand it over to Candace for some closing remarks, but I just wanted to thank all of our speakers this morning. Very engaging presentations on a range of issues, two very distinct examples of courts. And thank you to Megan for sharing the research from our work together, and to Kwasi for really showing, you know, the shifting landscape that's happening and the punitive and history of racialized drug policy that we have here in Canada and Ontario. So I'll turn it over to Candace for some closing remarks.
Thanks so much, Sean. And of course, the sun decided to come right into my office as I'm about to speak. I just wanted to note, for anyone whose questions did not get answered, please feel free to reach out to our team. Suda's email was put in the chat, but we can put all of our emails in there for any follow-ups today. So this does bring us to the end of our forum. This morning has been such a great opportunity to hear about some of the work that's being done with this project over the last 2 years, and hear the different perspectives from our various speakers, and of course hear from all of you. A lot of great questions and discussion today. I strongly hope that you enjoyed our time with us. On behalf of the project team, there are a few people that I'd like to thank. So a big thank you to our MC for the morning, Trevor, for guiding us through the morning agenda. A thank you to our entire project team who help us plan and execute this forum. And a big special thank you to Suda, who is our fearless leader in getting everything ready for today's forum. A lot of time and effort went into that. We'd especially like to thank our keynote speaker and panelists for all of their valuable insights, taking the time to engage with us. We appreciate your time and commitment to this work. And of course, thank you to all of you for attending, taking the time to be here and participate in shared learnings. As I mentioned, as was mentioned many times earlier, there are honoraria available for people with lived experience of substance use and/or involvement in the criminal justice system. So please do not hesitate to contact Suda so that we can get that organized for you. Please do not forget to fill out evaluation forms. So those will be sent to all participants by the end of the week. These are extremely helpful for us to hear your feedback so we can improve our planning and coordination of our events in the future. Again, a reminder that today's session was recorded and all of the slides will be available, and we will be posting it on the HSJCC website very shortly after this forum. We will put the HSJCC's website in the chat as well for you. The final final report for the project will include not only learnings from today's forum, but also a follow-up policy discussion, and infographics and other knowledge mobilization will take place, as mentioned earlier by Suda. CMHA Ontario, John Howard Society, and the HSJCC network and our various channels, communication platforms such as our websites, webinars, social medias, and newsletters will continue to be a really important platform for knowledge exchange for these issues and solutions that we've discussed today. And we really hope that you continue to connect with us on this project. Do not hesitate to reach out. The lines of communication are open. We thank you for your time again, and have a great day.